Good morning, everyone. Welcome to the Symposium Achieving Health Equity in Adolescent and Young Adult, Psycho-Oncology Care, brought to you by the University of Michigan Health Adolescent and Young Adult Oncology Program. And the webinar is co-sponsored by the Rogel Cancer Center, the School of Social Work at University of Michigan, and the School of Social Work Curtis Center at the University of Michigan. My name is Anal John. I am an assistant professor at the Michigan School of Social Work. I'm also the clinical research director at the Oncology Program. We would like to acknowledge before starting this session that we are working, learning, and living on stolen land within institutions that have been built by exploited and enslaved labor. We acknowledge and mourn the Black lives lost and exploited. We acknowledge that the University of Michigan is named for Michigami, the world's largest freshwater system and located in the Huron River watershed, was formed and has grown through connections with the land stewarded by Nishui, Ishkadawan, and Anishinaabe, the Three Fires people who are the Ojibwe, Odawa, and Potawatomi, along with their neighbors, the Seneca, Delaware, Shawnee, and Wyandot nations. Now it is my pleasure to introduce our event host, Dr. Bradley Zebrack, professor at School of Social Work, member of the Rogel Cancer Center, and the research director at UMH AYA Oncology Program.
Thanks, Anal. Good morning, everyone, or good afternoon, good evening, wherever it is in the world you may be today. I want to welcome you all and thank you for being here. I also want to start by thanking the University of Michigan School of Social Work and the Rogel Cancer Center for their support of the event today, along with the faculty and staff of the Vivian A. and James L. Curtis School of Social Work, Center for Health Equity Research and Training here at the University of Michigan. That includes the directors, Doctors Jacqueline Hawkins and Daphne Watkins. Also thank the staff, Kristen Tatter, Catherine Kloss, Jamie Abelson, for all your support and effort in getting the event together today. Today's symposium is the fourth in a series of events that have been held in conjunction with the Curtis Center's signature research program, which has really been critical in helping to establish an emerging infrastructure for research and training as part of the Adolescent and Young Adult Oncology program here at the University of Michigan. I want to give kudos to Dr. Cheung, who's an assistant professor here in the School of Social Work, as well as Nina Jackson Levin, a doctoral candidate in our joint program here in social work and social science, for all their efforts in helping to get this program together and move the needle on the science as well. There were over 135 people who signed up for today's event. And I really see that as an investment and a commitment to some of the important and emerging issues that are occurring in the field of not just adolescent and young adult oncology, but in oncology and cancer care in general. Particularly this emergence of a focus on outcomes and needs of persons who have been underrepresented and underserved in terms of research, clinical care, and support. We have a terrific panel today to address some of these new and emerging issues, and certainly some dynamic conversation and Q&A that'll follow towards the end. If I could just take a host prerogative for a moment, just say, just try to summarize in one or two sentences 40 years of psychosocial research, that has involved many of the folks here in this room in terms of identifying or describing the impact of cancer and its treatment on adolescents and young adults. We've made tremendous strides in understanding the outcomes and the needs of this young adult population. Many of you have been involved in then the creation and evaluation of interventions and supportive care programs to address some of these impacts of cancer on young people's lives. And while we've done a good job of establishing this knowledge base, I think where we're moving now is to move beyond an understanding of the impact of cancer on people's lives and get a better handle around the impact of people's lives on cancer, how it manifests biologically, how the social and environmental context in which people live manifests not only in biological changes and tumor progression, but even the abilities of folks to be able to access care, benefit from care, and achieve positive health outcomes. I find it kind of ironic as we move into this. It seems like over the last few years, there's been an emergence of a focus on social determinants of health and this new notion of social care in medical care, as if this is something new. I don't think I have to tell a room that's full of many social workers, both here in Michigan and virtually those of you who are joining. Social workers have been involved in the mitigation and the redress of social determinants of care for over 100 years. If we recall Ida Cannon being hired at Massachusetts General Hospital as the very first medical social worker. We have a very long track record of addressing social determinants of health, addressing issues of racism, oppression, and discrimination as it plays out in the clinical care context. So today really represents an ongoing opportunity for social workers and those also providing supportive care to cancer patients. And today we're focusing on the needs and outcomes for adolescents and young adults. But I think what we're talking about today really has ramifications for people in the cancer care context of all ages. So with that, again, I want to thank our great panelists for honoring us today. We're very appreciative of you taking the time to be here. And now I want to turn things over to Dr. Emily Walling. Dr. Walling is the director of our Adolescent Young Adult Oncology program here at the University of Michigan. And she's very much responsible for the viability of that program today. So Emily, take it away.
Thank you so much, Brad, and welcome everyone. Thank you so much for joining. I am honored to be a part of this panel and am excited for the discussions to follow. So I know this is an educated room, but I just want to orient everyone to who are we talking about here. So when we say adolescent and young adult oncology, this is an age-defined group by the National Cancer Institute of those who are diagnosed with a malignancy between the ages of 15 to 39. And so this represents a small fraction of cancers, less than 5%, translates to less than 90,000 new diagnoses annually. But it leads to over 650,000 AYA cancer survivors in the US, and this is data from the year of 2021. Our 5-year relative survival is 86%. Again, this data is a bit outdated, but you might look at this slide and think, this looks pretty good. What is kind of the big deal? What is the focus here? And This is the slide that really sums this up. So this was pioneering work done by a pediatric oncologist, Archie Blyer, through the surveillance and results, cancer program through the NCI. And so let me orient you to this slide. On the y-axis, we're talking about average annual percent change in survival. And so the green bars represent gains in survival, right? And you'll see that those less than 15 and those greater than 50 are all in green bars, right? But what is going on with this group in the middle? So they are losing gains in survival by annually as the years go on. And credit to Dr. Zebrack for this slide. I'm sure many of you will recognize it. And so, when we talk about why is this? Why is this group that is relatively young and healthy? Why aren't they enjoying the same gains in survival as their younger and older counterparts? And what this slide represents and highlights is that those diagnosed with a cancer between the ages of 15 to 39, this really represents a collision between pediatric malignancies and what I call adult, which makes me sound like a kid, but adult malignancies that are treated by medical oncologists. And then further, when we break down even the younger groups, these, 15 to 24-year-olds, this slide highlights how even within this, 9-year age range, we see a pretty dramatic shift between the most common cancers. So you'll see that lymphoma stays number one, but for the younger kids, that's followed by leukemia and CNS tumors. And this changes when you get to 20 to 24-year-olds to invasive skin and male GU systems. And the cancers highlighted in the colors just kind of show how these main cancers, the proportion really significantly changes over time. And so that, these contributors to poor outcomes are really multifactorial. And there are some that are, outside of our control, the biology, the types of cancer, the distribution that these patients are at risk for. There seems to be more aggressive patterns of malignancy as you age, i.e., higher risk genetics, higher risks of malignant disease at diagnosis. And this, in some sense, is kind of out of our realm of control. But I would argue that these last 3 bullets, these are what we can impact. And, particularly when we get to access of care, this kind of dovetails into the biology a bit. And so something that we as, oncologists and social work researchers think about a lot is that these patients have the lowest proportion of enrollment on clinical trials. And what that means at an individual level is they don't have access to kind of the latest, care for their cancer. But then on a population level, we know less about their biology. And so none of these are kind of standalone contributors to poor outcomes. The final 2 bullet points, treatment adherence, this extends to not only chemotherapy and medication that we ask patients to remember to take every day sometimes, but also to, surveillance exams and enrollment into survivorship. And so fewer opportunities for learning about treatment-related morbidity or other health conditions they may be at risk for. And then finally, which this cannot be understated, are the unique psychosocial stressors that certainly impact all these other contributors to poor outcomes. And so, kind of why is this relevant to everyone? So, if you think back to my first slide about, the number of survivors, we need to reframe our thinking about what does survivorship mean in the face of a diagnosis and treatment-related morbidity. And, in fact, at a recent annual meeting for the Children's Oncology Group, which is the international consortium that drives our pediatric clinical trials, there was an emphasis at certain talks that the typical ways that we think about as oncologists of survival, and that is like event-free and overall survival, are woefully incomplete and inadequate for capturing what survivors of pediatric or AYA cancer are dealing with. As Brad alluded to, we are now in the point of AYA oncology psychosocial research where general unmet needs and the psychosocial impact has been really well described. And so the next challenge is what's next? What are we going to do with this information and what hasn't been adequately explored? And further, we should recognize that within this age-defined group, that already experiences disruptions to, what are very traditionally defined developmental milestones that, many AYAs don't follow anyway. But AYA oncology patients, they're not a homogeneous group. And I think what's so exciting about our panelists today is that they're collective work really shines a light on particularly vulnerable populations that are encompassed within this age-defined AYA patient population. So it is my pleasure to introduce our panelists. I'll start with Dr. Christabel Cheung. She is joining us from the University of Maryland School of Social Work, where she is a member of the Greenbaum Comprehensive Cancer Center. Her work focuses on social determinants of health, particularly with a focus on anti-racist efforts. Nina Jackson Levin is coming from our home institution here, has a master's in social work and soon to hold a dual doctorate in social work and anthropology. She is a key member of our AYA cancer research panel. Her focus is on oncofertility and particularly the needs of sexual and gender minorities. Angela Usher is joining us from the UC Davis Cancer Center. Dr. Usher is the manager of the Supportive Oncology and Survivorship program there, and her research focuses on rural health inequities and access to care. And then last but not least, Dr. Kelly Irwin is joining us from Harvard Medical School, and her work focuses on those with severe mental illness and how that can contribute to health disparities and impact cancer diagnosis, treatment, and survivorship. So I will hand it over to Dr. Cheung. Please take it away.
Thank you so much, Dr. Walling, and thank you everyone for being here today. So I really want to begin my talk by adding a little bit more to my self-introduction in terms of, I'm an assistant professor at the University of Maryland School of Social Work. In addition to that, in addition to my work on anti-racist engagement of adolescents and young adults in oncology research, I wanted to share with you that I come from an orientation of being an embodied researcher, what I have coined as an embodied researcher. And what that means is that I am also myself, I identify as a BIPOC researcher, and also I'm a 2-time survivor of Hodgkin's lymphoma in the AYA years and a bone marrow transplant beneficiary myself. So I bring that to this work, and that's important in this context of transparency and reflexivity, because I will be sharing with you some of my qualitative research outcomes. So I'm ready for the next slide, actually. So in terms of anti-racist patient engagement, I think it's important to begin this conversation by first defining what we mean by anti-racist, what we mean by patient engagement. So first of all, anti-racism really speaks to the idea, and I base my work on the theorizations of Dr. Ibram X. Kendi, where he explains that there is no such thing as not being racist, that the heartbeat of racism domestically in the United States has been denial of racism, and the sound of that heartbeat has been the argument, I'm not a racist. And he encourages us to take on the perspective that we're either being anti-racist, where we're promoting equality, or we're being racist in the sense of working within systems, either being complicit or actually supporting racist approaches. So that's that aspect. Patient engagement. So patient engagement means two different things. Patient engagement can mean the engagement of the patient in a clinical encounter with healthcare providers, and in this study, I really focused more heavily on patient engagement in the conduct of research and advocacy efforts. So I drew upon the PCORI framework for patient engagement, which you see here in 4 quadrants. Starting in the upper left, there's topic selection and research prioritization. To the right, proposal review, design, and conduct of research. Below that, dissemination and implementation of results, and then finally, evaluation. So these are all research activities. This has been an organizing structure around which I worked with colleagues really under the mentorship of Dr. Reggie Tucker-Seeley and Dr. Kim Miller and Dr. Mark Lewis and many others in the AYA oncology space, we came to specific recommendations from a professional perspective of what we feel we can do in terms of advancing anti-racist approaches. And so in terms of, I'm just going to give you the highlights in terms of topic selection and research prioritization. We really suggested that we need to extend the timing of patient engagement earlier on in the process. The idea that we're engaging with those who are most impacted by the research too late is something that we're mindful of and want to do something about. Secondly, in terms of proposal review and the design and conduct of the research, we suggested that we need to provide education and honest disclosure to the AYAs who are our patient advocates in terms of what their involvement entails. Thirdly, in terms of dissemination and implementation of results, we want to avoid persistent tokenism. And one way of doing that is to stop using the same AYAs over and over in terms of patient advocacy roles, right? So being a BIPOC AY advocate myself, I know the handful of half a dozen of us who in my cohort, now I'm one of the older adults of the AYA thing, but those who were in my cohort, you know, I was the Asian girl with the dog, the Asian girl with the service dog. We knew who the Black female cisgender, you know, identified individual was. We knew who the Black male gay AYA representative was. We became tokenized in those roles, and it was unfair to us and unfair to the entire population because we cannot possibly represent the range of issues that all marginalized and minoritized AYAs face. So moving on to the next slide. In this latter part of my study of anti-racist approaches to patient engagement, I did a Delphi study of 32 exclusively BIPOC AYA cancer patients, and I asked them to share their experiences of anti-racist approaches, essentially. And so I will tell you that, you know, we want to take those experiences and offer to all of you as practitioners, as policymakers, as researchers. We want to offer you best practices in how to better engage with BIPOC AYA cancer patients so that we can improve the knowledge, center patient wisdom, and prevent unnecessary suffering that is happening right now. It's very important for us to be mindful of the socio-political context that we're in. Right now, there's a run on BIPOC, LGBTQ+ AYA participants for studies. And so it's very important for us to enter into research being self-aware of the time that we're asking of our participants, how we're compensating them, and what they can expect, right? And to be having that conversation across the entire process. So the number one core value identified by both professionals and BIPOC AYAs themselves was the value of transparency, honesty, and trust across the research process. So for me, in terms of my work in engaging with both professionals and BIPOC AYA cancer patients themselves, I wanted to create a harmonious, co-developed set of vital best practices for all of us to inform our work. So one of the quotes from a BIPOC AYA in our qualitative research process about transparency, honesty, and trust really speaks to an experience that I think is important, an important snapshot into what it's like when transparency, honesty, and trust is violated. So this young person says, the premise of the company was they provide genetic testing sample kits for cancer survivors. What they didn't tell people who are signing up is they're also going to sequence data to try to come up with, you know, new medicines. So they're doing research on top of research. When you sign up to participate in a study, you should be told exactly what's going on. So young people know, they know that their information may be used in ways that they're not consenting to. For me as a researcher, this raises all kinds of like, what happened to IRB, kinds of bells and whistles. But moving on to stage 1, topic selection and research prioritization, here's a snapshot into what an experience or what BIPOC AYAs are asking for. This young person says, there has to be diversity at the helm. I found the makeup of the team and leadership to be reflective of the participants and its audience. Having representation of people of different races, ethnicities, and cultures sets the tone of what their opinions, experiences, and knowledge is. So being able to see representation on the study team, having the faces of the study team be visible to participants is very important in order to build rapport and also validate that the topics that are being discussed are of relevance to that population. In terms of proposal review, this young BIPOC patient says, along with providing education regarding the research, the study team alerted us, and I'm sorry, I should preface this by saying this was a good experience of an anti-racist approach. So along with providing education regarding the research, the study team alerted us of what we get in return. Regardless of their race, many teens and young adults know that their time is worth something and will expect something in return, even if it's just the chance to help make a small change in the way something related to cancer treatment happens. Alert them of this. So we're not, participants are not asking you to lie to them and say they're going to make this great impactful change in the world, but to be realistic and honest about what small change you're hoping to affect in this study. In terms of dissemination, I feel like this insight into the dissemination, actually partly the evaluation process, is very important. So this former participant on studies, this BIPOC participant says, I've been brought into patient advocacy circles because of my proximity to people who are part of the research, maybe because I'm relatively privileged myself. So amongst our participants, they are aware of their positionality and what they are capable of commenting on and what they're not. But oftentimes as researchers, we ask them to represent and comment on topics and issues that they're not knowledgeable about, right, based on their embodied and lived experiences. In terms of evaluation, very bluntly put, one young participant says, it's hard for me to feel valued when not receiving compensation. So being compensated for time is just an objective factor that we all need to address. And we, in our work, it's important for us to remember that this period of the last couple years, last few years, basically anything that happened after 2020 is a response to this renewed awakening amongst predominantly white institutions and research teams about the need to be inclusive. In addition to thinking about creative new ways to reach BIPOC, LGBTQ+, marginalized and minoritized patient populations, it's ever more crucial to remember that we have been reaching them all along. We've been reaching them in ways that may be offensive or otherwise off-putting. And so how can we stop doing that? That may be the first question before we start asking, how do we get more on? We need to stop what we're doing that's harmful first. Thank you very much. And so now I will pass it on to one of my amazing collaborators and colleagues that I'm so proud of. She's currently a PhD candidate at the University of Michigan, working on her dissertation, came out of all of that to talk to us today. Soon to be Dr. Nina Jackson Levin.
Thanks so much, Dr. Cheung. And thank you all for being here. So excited to sit on this panel and to speak with all of you today about AYA health equity. I'm going to be talking about sexual and gender minority AYAs. I'm going to use the acronym SGM. I'm also going to say LGBTQ and use the word queer interchangeably. And now if you could go to the next slide. So Speaking of language, let's start there. There's a lot of text on this slide, so let me walk you through it. I think it's always important to get really clear about the language that we're using when we're talking about this population. And so I'm going to talk about 3 dimensions of identity that are at play here. We talk a lot about LGBTQ as a spectrum, but in fact, there are multiple coinciding and related spectra within that broad spectrum. And so it's helpful to kind of think of this in terms of three dimensions or 3 domains. The first is sex. Sex refers to biological or physical attributes. This includes external genitalia, internal reproductive organs, and chromosomes. And a person can be male, female, or intersex. Sex is often assigned at birth based on external genitalia. And so when we talk about gender, gender refers more to one's internal sense of self with respect to a multitude of genders. Gender is not necessarily male or female. Cisgender and non-cisgender, again, echoing, Dr. Walling's comment at the top of the conversation that this is a highly educated room, and these terms are more and more familiar in the general discourse. But just to remind folks that cisgender refers to a kind of order of gender in which sex assigned at birth aligns with one's internal sense of self. So, for example, if a person is assigned female sex at birth and feels an internal alignment with womanhood, that person would be cisgender. Someone who is non-cisgender is someone whose sex assigned at birth does not align with their internal sense of self. So someone who's not cisgender may be non-binary, transgender, or a number of other identities along the gender spectrum. And sexuality refers more to sexual and or romantic attraction to others. So sexuality describes the more interpersonal domain of sexuality as a construct. And again, reminding the group that heterosexual and non-heterosexual describe 2 broad orders of sexuality. Heterosexual describes a person who is cisgender, who's attracted to someone of a different gender. So someone who is born male, assigned male at birth, feels an alignment with a masculine identity and is attracted to a cisgender woman. Non-heterosexual refers to a person who's attracted to the same or various genders. Someone who's non-heterosexual might be gay, lesbian, bisexual, pansexual, asexual, or a number of other sexuality identities along the sexuality spectrum. It's also important to point out that all these 3 dimensions and constructs change over the course of a person's life. So these are all fluid, interrelated, changing aspects of identity. And then at the bottom down here, 2 terms that are kind of important to keep in mind as we move through this work. So the term cis-heteronormative refers to an ideology that what is normal, meaning what is statistically most frequent in the population, is normative, meaning that it is the morally correct way to be human. And so queer as an ideology disrupts and interrogates the notion of normativity, which is that that which is most frequent is the most right way to be human. And we know, that there's enormous diversity in gender and sex and sexuality in human beings. So if we could go to the next slide. So let's talk a little bit about what we know and about the how many people fall into these categories. And I will say as a caveat, this slide is this is an estimate. One thing that the field is lacking is consensus-driven empirical data about how many sexual and gender minority persons exist in the United States, and then even further, how many SGM-AYA cancer survivors and cancer patients we're talking about. So my caveat would be that these numbers are my own calculations, and they are an attempt to illustrate what we do know about the population, but these are not necessarily derived from empirical population-based studies. So with the exception of sexual and gender minorities in the United States, this data comes from a 2022 Gallup poll, which indicated that 21% of Gen Z, those born between 1997 and 2012, identify as LGBT. And 11% of millennials born 1981 through 1996 identify as LGBT, compared with only about 8% of adults who are born before 1980. So the ascendance of this population and the growth of this population is due to a number of factors, and we have to remember that cultural change is a huge part. So what this is really saying is that more people are disclosing these identities. It is not so much that these identities are more prevalent on their own. Disclosure and acceptability and activism and positive representation are all a part of this growing population. So if we were to sort of take the average of the Gen Z and millennials, which are the generations that comprise the current cohort of AYAs, those ages 15 to 39, we can sort of estimate about 15% of those individuals may be SGM. So if we take 15% of what we know, we know there are about 650,000 AYA cancer survivors, as Dr. Walling mentioned earlier. So roughly 15% of that gives us close to 100,000 AYA cancer survivors who may be SGM. And if we take 15% of what we know to be the annual incidence of new cancer cases, which is approximately 87,000, we come up with about 13,000 new AYA cancer cases that may be of SGM individuals. So we're talking about a notable percent of the population. But even if these numbers were smaller, it's still important to attend to these groups because these people exist and they have there are needs that need to be attended to. So that gives us a sense of the population. So let's move on to the next slide. So some of the research disparities, and I'll move through these pretty quickly, and we can talk more in the discussion, are related to sampling. This is a difficult to reach population, and there are specialized approaches that are required to reach a population who can only be identified based on self-disclosure. We're doing some work here at U of M to get some empirical data around what those approaches need to be in order to effectively reach this population. I talked earlier about those multiple different constructs related to the population, and there's not field-wide consensus on how to measure these constructs. So in the absence of consensus, there is missing data from medical records, registries, databases. And so there's just a general lack of knowledge so far about how to measure the different identity components within this population. And as a result, we lack generalizable knowledge base at this point. We're lacking in cohort studies or endpoints in clinical trials related to these groups. So there's a lot of work being done recently, but the gap historically has positioned us as a field to be disadvantaged with this knowledge now and with the need to grow. Clinical disparities, there are higher risks for certain cancers among SGM, and yet there's lower rates of preventive screening across the board within these groups. So building equity around screening practices is vital. Patient and provider interactions, there is historic fear of discrimination amongst LGBTQ patients, and there's fear of homophobia. And then when we're talking about AYAs, which comprises minors, sometimes they're not out to their parents. And so that can be a barrier to accessing services that are necessary. Oncofertility, which is sexual and reproductive health counseling and fertility preservation counseling, is not always tailored to the needs of this population. And studies have shown that there is lower referral rates among SGM population to fertility preservation services. Sometimes the assumption is that if a person's queer, they may not want to have children, but that's not necessarily the case. And so there's a disparity there. And then finally, transgender care is a nascent field, and little is known about medical gender transition during cancer treatment or fertility preservation for transgender individuals. So clinical disparities exist there, and there's a lot of work to be done, and there's a lot of work that's going on to address these. And then I'll move through this very quickly, just to remember that even though we're talking about health disparity, we have to remember there's unique resilience factors within these populations. There are ways in which we can think about, instead of thinking of compounded vulnerability by being both a vulnerable AYA, age-related, and both a sexual or gender minority, that at the same time, there are unique resilience factors that we need to leverage as we build health equity for LGBTQ AYAs. So thank you so much. I'm going to hand it off to Dr. Angela Usher, who's going to talk about the geographic impact of young adults with cancer.
Hi, thank you very much. I'm excited to be here. My name is Angela Usher. My pronouns are she, her, and I'm excited to be talking about the geographic impact of young adults with cancer. So for the nearly 1 in 5 US residents living in rural and remote areas, access to health services can be difficult. This means roughly 59 million people face disparities in obtaining routine healthcare. As you can see from this graphic from Transamerica Center, the rural residents are less likely to rate themselves as being in excellent or good health. They are more likely to have health insurance, to be underinsured or uninsured, and they are more likely to work jobs that do not offer either disability insurance or medical leave, and they are less likely to use medical health technology. Access to cancer treatment can be even more difficult. A workforce analysis done by the American Society of Clinical Oncology found that only 3% of medical oncologists and less than 0.4% of radiation oncologists worked in rural areas. For psychosocial care, only 2% of medical social workers, and these aren't oncology specific, that's even more rare, is employed in rural areas. Well-documented disparities in rural cancer include less preventative education and detection and screening efforts. My phone keeps buzzing, sorry here, let me get rid of it. And less options for ability to participate in optimal treatments like radiation and clinical trials, as well as rural residents have higher cancer mortality rates. The average annual death rate from all cancers in the most recent 5-year period was 180 deaths per 100,000 population in rural areas, compared to 158 deaths of 100,000 populations in urban areas. I want to call out distance to treatment as slightly different than rurality, because people can live in more urban type environments, but yet need to travel significant distance, as most cancer treatment programs exist in large towns and cities, and nearly all NCI comprehensive cancer centers are in large urban areas. This is especially true of cancer centers that offer programs specific to young adults and for specific access to AYA cancer treatment. This often means a significant travel distance. Distance to treatment not only impacts the patient, but also the caregiver. And if the patient has dependent children or other dependents, it impacts the whole family. We have a young woman right now going through gynecologic cancer treatment, and her mother brings her and her 2 toddler-age children to chemotherapy, because this patient does not have the help with both transportation and childcare. She must rely on the same person. And when you think about the time that somebody's sitting in a chemotherapy chair, and for this patient, it's 2 to 3 hours, plus the 2-hour drive each way, that's a very long day. It impacts the entire family, and it's costly between the cost of gas, the parking, the meals, and other indirect costs that she faces. Because so much time and resources are given to travel to get to treatment, staying additional time to see a social worker, a navigator, a dietitian, or even to attend a support group is not always possible. In the last 3 to 4 decades, national, state, and local government efforts to do anti-poverty towards children and elderly have been somewhat successful, and they have reduced poverty in these populations. However, poverty in the United States for young adults is currently the highest among any age group. And for adults in their late teens and early 20s, up to mid 20s, nearly 34% are living within the lowest poverty levels. This is significant. The significant spike in young adult poverty really started to take hold in 2008. And some theories as to why young adults are more vulnerable to greater poverty in the past include shifting economic priorities, imbalance of low wages versus increasing cost of living, ballooning educational debt for all types of opportunities for education, and a lack of a national priority to create a safety net for young adults. As mentioned previously, rural areas have the highest rates of unemployment, highest rates of uninsured, and highest rates of underinsured people. Many large rural areas are in states that did not choose to expand Medicare, leaving young adults with less options to access medical care. This double whammy for rural dwelling young adults is also compounded by the types of work in rural areas are often agricultural, forest service, retail, and tourist related. These jobs typically pay low wages and do not provide adequate paid sick, disability, or employer provided insurance. There is a significant lack of research on degree of virality and the impact it has on psychosocial health outcomes. So I want to acknowledge that some of what I'm doing is extrapolating what I've learned on the general public to apply to young adults. And this is definitely areas where we could be doing more young adult related research. Next slide. It is important to know that young adults living in rural and remote areas in the United States are not a homogeneous group of people that fit into a rural culture. Rather, that with all cultures derived from ethnic and racial identity, people from rural America fall along a continuum of acculturation into mainstream. As well, degrees of rurality have impacted how people experience culture. And without going into the weeds, because there's a lot of weeds here, the rural-urban commuting codes defines degrees of rurality based on population size and commerce. And they have 10 categories of rurality with additional subcategories. Intersectionality is an important framework for understanding the experiences of young adults with cancer from geographically varied areas. Many rural regions have populations who primarily speak Spanish, Mien or Hmong, Urdu, Russian, and Hindi. In addition, many American Indian reservations are places that are considered rural. Religion can often play a strong role in shaping small community culture and impact a person's ability and attitudes towards medical care and mental health care. When identifying disparities among populations in rural and remote areas of the US, it is important to understand the role of privilege and social justice within the realm of healthcare, cancer prevention, and survivorship. People who are experiencing poverty, food insecurity, employment loss, lack of medical and financial safety net are also dealing with racial and ethnic discrimination, homophobia and transphobia, anti-immigration, and discrimination based on age, ability, and gender. It all impacts a patient's willingness to trust, to seek help, and receive help in the context of psychosocial oncology care. Based on general adult studies on the impact of rurality on cancer patients, one may infer that young adults in rural areas face food insecurity, transportation barriers, and financial hardship at greater rates than young adult patients who live closer to treatment. We also know from the literature that accessing and utilizing psychosocial care is less than optimal for patients in rural and remote areas. In one study, up to 57% of the rural and remote population had no idea psychosocial care even existed at their cancer center. Patients from rural and remote areas report even greater need with help navigating the logistics and the resources to access treatment care. Another study that I looked at, and that's okay, don't worry. Another study that I looked at on rural-urban disparities found that rural patients, young adult patients were far less often offered information and help with fertility, preservation, and sexual health. From the 2019 NASEM report, Integrating Social Care into the Delivery of Healthcare, Moving Upstream to Improve the Nation's Health, the emphasis is on the 5 A's. For this approach to work, it requires us to be an interprofessional team where the responsibility of all members is to be aware of and work on detecting the health-related social risks and help mitigate them through the 4 A's, adjustment, assistance, alignment, and advocacy. With each profession as it has its own strength, philosophically, the detecting and addressing of social risks is as important as dealing with the disease of cancer. Awareness can be a lot of very different things, and I want to give a couple examples of all these different pieces, but I'll try to do this really quickly. So awareness could have a lot of different methods, but it's really creating a culture where the whole oncology team is aware of the issues that face young adults, and they're speaking to them. So it's not just the social worker who gets brought in during a crisis, but from day one, people are asking questions about people's staff are asking questions about patients' social risks. So that should be a multimodal and multiple offered assessment. It should be part of the conversation with each appointment, so that people have time to trust, patients have time to trust and can build the confidence to share what their needs are. As well, adjustment to cancer treatment would be allowing video visits or stacking appointments so that there's less trips for our patients who travel distance to get to care. Assistance would be providing actual physical, practical assistance. And the example that I have here is at our cancer center, we pay for lodging for people who live greater than 35 miles or more, so that they can stay locally. Alignment is also working with other agencies and creating solutions. And so I'm going to go back to the housing one, which is we partner with our local nonprofit Kiwanis Guest House, as well as I've applied for and was granted a number of ACS, American Cancer Society grants to pay for lodging, and so that we can help our patients that way. And then finally, advocacy. And I think that this is the one that we really want to be working towards, because this is the upstream part of this all. One example is in 2019, many states, after many years of advocacy, enacted laws requiring private insurance to cover the cost of fertility preservation for individuals of childbearing age, or for our younger patients, potential childbearing. That fertility would be financially covered as part of any medical procedure that presented a risk to somebody's fertility. So although wonderful and great, and I'm glad we were able to accomplish this, the same states, and California is one of them, and that's where I work, made it so that Medi-Cal was exempt. Medi-Cal didn't have to pay for oncofertility. So I want to call out one of the organizations, the Alliance for Fertility Preservation, which does a lot of education and advocacy work. And I want to really emphasize that we need to keep pushing Medicare and Medicaid, Medicaid. I'm used to Medi-Cal in California, so forgive that. But Medicaid really should be paying for this vital service. And last slide. So I want to thank everybody for coming, and I get to pass the baton here to Dr. Kelly Irwin, who's going to wow us and enlighten us with her work in mental health and AYA oncology. Thank you very much.
Thank you so much, Dr. Usher. And I want to really thank all of the panelists and our hosts for this really strong focus on intersectionality, on asking all of us to bring our own identity into the room when we think about these questions and how we can move forward toward equity. In that spirit, bringing my identity to the room, I'm a person who lives with a mental health disorder, and that's part of what informs the work that I do in terms of clinical care, advocacy, and research. Next slide. So if you Google Cancer Center and you Google mental health clinic, this is what you see. You see a bright, shiny glass building, which we invest millions of dollars in, and you see a strip mall. And the result of that kind of fragmentation and structural discrimination is a huge mortality gap. So people who are living with serious mental illness, we can talk about how to define that, as schizophrenia and bipolar disorder, or more broadly as severe major depressive disorder and post-traumatic stress disorder. Not a small group, at least 5% of the general population. But this group of people living with serious mental illness dies 30 years earlier than the general population, and 80% of that mortality gap is from cancer. So we can get more narrow and delve into that. We can think about a gap of maybe 15 to 20 years and what might be modifiable factors that we might want to target in an intervention that attacks some of these multi-level contributors to disparities in ways in which we can hope to not just only close this mortality gap, but also improve quality of life and relieve suffering and address some of the issues that we've all been talking about together. Next slide. So in the spirit of trying to understand what might be modifiable factors that we could target in intervention, I'm a psychiatrist, I'm a physician first, I'm someone who like sees a patient in front of me, wants to get them their cancer care, but also someone who's stepping back and wants to think about these multi-level factors that are impacting cancer outcomes. When we take a step back and we think about a group of people affected by mental health disorders, what we see are that inequities across the cancer care continuum and how those inequities impact outcomes. And we also acknowledge that for AYAs, these are perhaps the first time in which people might be getting a diagnosis of bipolar disorder or an eating disorder or an emerging psychotic disorder. We also recognize that during the pandemic, mental health needs have escalated and escalated and escalated so more. And we also know that there's just a fundamental lack of mental health treatment in the United States and globally. And that's more pronounced for people who are AYA, meaning more than 60% of people who are 18 to 40 who have a known mental health diagnosis are not getting adequate treatment. So if we think about that intersection, let's look at the cancer care continuum. We know that people with a history of mental health disorders are not getting adequate screening. They have higher smoking rates and are less likely to be prescribed, guideline concordant care for their smoking that can help. They're less likely to get diagnosed on time, have lower rates of receiving needed radiation or chemotherapy or surgery. They're less likely to be referred to palliative care. Fundamentally, these inequities are impacting outcomes in terms of quality of life and survival. And although we might often focus on patient level factors, it's important, I think, as all of you guys are guiding us in the discussion, to think about the structural discrimination at the center and how that impacts not just patients, but clinicians, the design of the healthcare system itself. And that will help inform, I think, our next steps for how we can mitigate these disparities. Next slide. So we talked about some of the barriers that the AYA population experiences when accessing clinical trials. 1/2 of clinical trials systematically exclude people with mental health disorders, including substance use. So it's just a written exclusion criteria. It's hard to get past that one. It's one we can do something about. As one medical oncologist shared, there are people who falsely assume that patients can't give informed consent or won't understand. People kind of write off this population. Next slide. So a little context, a patient who had participated in our recent randomized trial, a 26-year-old woman who had experienced a lot of loss in her life, and she's a collaborator in our work and wants her story to be shared. Her father had died from suicide when she was little. Her mom died from an overdose when she was 15. She had recently had a baby, about 6 to 8 weeks old, when she got diagnosed with breast cancer. She experienced delays in having the symptoms she presented with being validated, recognized as real. She did get connected to a cancer center and had care recommended for her triple positive invasive breast cancer. At this time, she agreed to partner in the research as a strategy to help other people who are affected by mental health disorders and cancer. She was not currently taking medications, but she did have a significant history for being hospitalized for suicidal ideation, hopelessness, and impulsivity multiple times. Next slide. All right, so mental health discrimination is pervasive. It means we don't talk about brain illness very much. We kind of suck at talking about it. And for patients, that means they experience shame and isolation, which leads them being sometimes delaying presentation to doctors and hospitals, which leads to preventable delays in their cancer treatment. Clinicians may feel helpless to address the complicated comorbid challenges that they may face. And when we feel helpless, we're less good at stepping back and thinking about the strengths and resiliency factors that were mentioned earlier, which can help guide our approach to treatment. At a structural level, even though we have national mandates for psychosocial oncology care, we fundamentally don't invest in it. We don't invest equally in research, and therefore we don't lack the evidence to guide the treatment. And when we have a huge challenge like the pandemic, if we keep doing things the same way, our default approaches simply will widen those disparities for marginalized populations. So the take home in terms of transparency, so the way our healthcare system is currently designed, it's failing marginalized populations and really failing us. Next slide. So what do we do about it? We heard a lot of good ideas already. So first of all, you got to keep it real. You got to be transparent and acknowledge the injustice that exists. We need to think about what person-centered teams are and how we begin with people's strengths. We need to think about the data that's already available in our medical record and our claims data, how to leverage that to understand who might benefit most from interventions. We need to think about what evidence-based models are and how we can get those to people who need it, and using a mixture of technology and in-person engagement strategies that are co-designed and informed by people who are affected by these conditions. We need to think beyond the healthcare system and build communities of practice with engaged the organizations, community organizations, schools, workplaces, churches, et cetera, all the places that have a shared interest in moving the needle in terms of health equity. And we need to apply a social justice and human rights framework to guide those best practices. So in that spirit, as I said, I'm a doctor, physician, interventionist first, and I wanted to not just describe, but do something about it. So we identified a really strong modifiable factor, which seemed to be associated with whether or not people with pre-existing mental health disorders got the cancer care they needed. And that modifiable factor was access to psychiatric treatment at cancer diagnosis. Next slide. So with that spirit, what we wanted to do was build a clinical research and advocacy program, which was designed to increase access to person-centered care, including psychiatric care, starting at the time of cancer diagnosis. So we designed an intervention to help to increase access to that person-centered care using a team, using a strengths-based lens. We piloted that model. We just conducted the first randomized trial in this population. And at the same time, we built a coalition, which is called the Engage Initiative, or Cancer and Mental Health Collaborative, which is guided by advisory boards, which includes people with lived experience of mental health conditions and of cancer, to shape our agenda. Next slide. So we talked about language, and I know in some ways I'm preaching to the choir here, but the reality is that language about mental health disorders remains very pervasive in our medical setting, in the words we use. And when we try to think about a lens of how we can be more specific and words that can avoid shame or blame, but instead then focus on action, here are some examples. Some language we might use more casually, like that's crazy or insane. Some language we might have an understanding of the fact that we're trying to be more specific. So trying to say a person affected by a condition, thinking about someone who is in recovery rather than clean, and even some default language that was in our medical templates. Why do we say chief complaint or patient failed treatment or no-show or non-compliant? What might be alternative language that takes the blame off of the person and instead helps us to all take responsibility together? All this language matters. Next slide. So what's the model? So we have a population-based strategy to identify people who have a history of significant mental health disorder. For our studies, we define that as schizophrenia, bipolar disorder, and severe major depressive disorder, but you could argue about other ways to define that. So we try to identify people at the time of cancer diagnosis. We don't just rely on the medical record. We've also built a partnership with community mental health agencies and other organizations that serve this population, so we don't just capture people already in the cancer center. And then we bring together not just the oncologist and the patient, but the person, and if there's a caregiver involved, along with a psychiatrist, social worker, and the oncologist together, who with an understanding of the person's goals and their illness understanding, create an integrated cancer and mental health plan. And then we, in terms of the tenets of collaborative care, systematically monitor their response to treatment using evidence-based measures. And we also partner with a navigator to address some barriers to care, come them through treatment. That's the idea, that if we have this kind of an approach, could this help for people to get the guideline concordant care they need? Knowing that these rates of delays and disruptions in care were quite high, but we were trying to come up with a strategy, a person-centered care strategy that would both increase access to mental health care by using a collaborative care approach, but also have the chance to be meaningfully associated with more likelihood of getting the cancer care they need. Next slide. So this is the randomized trial that was funded by the National Cancer Institute that we're just completing. And one of the things that's different about our approach compared to other collaborative care approaches is just that the primary outcome isn't just improved depression or anxiety symptoms, it's whether or not they got their guideline concordant care. So we can take a look at that later, but just to move on, next slide. One of the things is just understanding ways in which we can meaningfully engage and partner with the population to participate in research. So even during the pandemic, it was important to show that we were able to identify the population to participate in a randomized trial, that they benefited from it with high rates of consent and completion. And that, additionally to that, we partnered with oncologists to really come up with a clinically meaningful way to understand whether or not they got guideline concordant care, which we defined as cancer care disruptions based on guidelines from the NCCN. And what we found is that on our control arm, which is called enhanced usual care, more than 1/3 of people had meaningful cancer care disruptions versus 17% on our bridge arm, in addition to improved anxiety, and psychiatric illness severity. So that the intervention was associated with people being more likely to get the guideline concordant cancer care they needed. Next slide. All right, so Julie, I think that we talked about a strengths-based approach and the fact that, she was experiencing a lot of challenges. The reality is that her mental health did worsen during treatment. She experienced significant symptoms of irritability, depression, worsening of her eating disorder. She had periods of being psychiatrically hospitalized, and she would have really struggled to access mental health treatment and, without having been connected to an integrated approach. I think she was blown away, surprised that she ended up needing this support, but it was also an opportunity for her to reflect on kind of where she was in her life. And as she's come through it, I think the other challenge is, as you guys who work in survivorship, it doesn't end there. How does this impacted her identity going forward? How has her voice been heard in cancer care? And what she talks about really most meaningfully is that she really appreciated the advocacy from the mental health team to make sure that when she reported a symptom, when she shared an experience, that the team really heard that experience as valid. Next slide. So as we're thinking about coming through the pandemic and creative approaches that we can help us partner beyond the Cancer Center, one fundamental challenge is how do we increase access to mental health care? And one approach that we've tried to use technology in a creative way is to modify our traditional tumor board model and instead think about an equity tumor board model for cancer and mental health that integrates not only oncologists, NPs, social workers from the Cancer Center, but also mental health clinicians, advocates, navigators from the community. By bringing those groups together, how can we build a community of practice that will have increased capacity to care for people who have both mental health needs and cancer? And how is that vision going to be able to be guided by people who also have that lived experience? Who might be in the room? How might that be different for AYA populations? I think that there are a lot of opportunities to think about creating these kinds of virtual communities of practice to expand our reach. Next slide. And so in closing, I certainly invite all of you to be part of our coalition, the Engage Initiative. I think that's consistent with the mission that brings us all here today, that we believe that mental illness should never be a barrier to cancer care, and that it takes all of us and a lot of humility and focus on improving outcomes to get where we're trying to go together. Thank you.
All right, great. At this time, I would like to invite all our panelists, having your camera back on, and also having Emily, Dr. Walling, have your camera on. We're going to do a 15 to 20 minute structured discussion, but we'll also make sure that we do get to the questions that have already been submitted. There are quite several questions there, so we'll get through these questions as well, making sure. But Emily, the floor is yours with all the panelists.
Thank you, everyone, so much. That was really wonderful, and I have lots of notes, and I will attempt not to monopolize the entire discussion with my questions. But I just wanted to, again, thank you and acknowledge that, when we were setting up this panel, we kind of partitioned people into slots, and we talked about how, with all your specific research, we talked about how that can intersect with a cancer diagnosis. But clearly people can be part of multiple groups, right, that you all serve. And so, I appreciate Nina's comment about how we can potentially leverage these areas of intersectionality, but specifically wanted to ask you guys if you think there are kind of other vulnerable groups that we haven't even discussed today, and also if you could comment on ways that kind of boots on the ground clinicians can be more, sensitive to these needs in the setting of kind of our focus on the cancer diagnosis and treatment. And I can pick someone to answer if that's helpful.
I just wanted to start with the boots on the ground clinician, and then I'll turn it over to my colleagues for some other comments. I think that it's been critically helpful to ask people what your strengths are. What are you good at? And if they can't answer that, what would someone else say you're good at? What are your hopes? what you most want, and integrating that systematically into your assessment is another way to capture the resiliency factors and have a more global impression of each person who's in front of us.
Thank you. Dr. Cheung, I was, curious, I appreciated your comment that stop doing what's offensive first, and I think, most people have good intent, but we can be offensive in ways that we don't intend. And if you have suggestions for ways we could be more inclusive as clinicians, researchers, without kind of, exploiting vulnerable groups.
Right, and I think that the aspect of involving individuals who are representative of the populations most impacted from early on in our planning, whether it's program planning or planning the way that we conduct clinical encounters, or how we plan our research projects, right, that are like maybe more time limited. I think having representation from leaders, having leaders involved who are representative of those populations is something that is still missing, because right now, currently with this renewed interest, it's the same leaders who are still leading this work, and they are tacking on BIPOC, LGBTQ+, other minoritized, marginalized team members who are actually subordinate to them. And so a power dynamic comes into play, right? Being actually a McKinsey report just came out that said that Asian American women at the C-suite level, suddenly we fall 80% below Asian American men in terms of representativeness, in the C-suites, at that level and at the board of directors levels. So, and that's compared to Asian American men, not even, not even the dominant Caucasian, right? Cis male group, right? So I think being mindful of genuine, meaningful inclusivity, because in that way, those voices that you bring on will actually be voices that have the power to be heard. I've long, been, I'm often the most junior and the only representation of BIPOC on the study teams that I'm on, in terms of being a co-investigator, or and I often ask for, hey, can you please add a senior member that's just BIPOC of any kind, just a senior member, because it is such a weight to put on, and it's tokenism, oftentimes, because I often feel like maybe I shouldn't even be a face in this meeting, because maybe I don't have the expertise to actually opine or give an opinion on what's going on, but my face is being used to check off the box, and I'm maybe doing a disservice to the populations that I care about. And so I think it's unfair. At the same time, sometimes there's this, because of the power dynamics, I feel like, well, I have to be on because my mentor asked me, or I have to be on because, this or that. I'm not talking about Brad. Brad is one of my mentors. So I just want to be clear about that. Brad is not twisting my arm to participate. So I think that those power dynamics always come into play for us. And it speaks to why oftentimes scholars of color, physicians of color get burnt out and leave their careers, leave academic research, because there is so much unpaid work that we're asked to do in addition to that. And that speaks to being a patient advocate as well. We ask our BIPOC patient advocates, BIPOC, SGM, sexual gender minority, LGBTQ+ patient advocates, especially right now, you know what? It's not enough that you cope with cancer. What, can you write a story about it? Can you just 500 words? Can you just 500 words do this for us? Can you just, can we just use your photo for the next 5 years on our website? Can you, can we? So it's these things that they, even when they agree and we fully consent, we need to remind ourselves that these are still developing individuals. Even as adults evolve, they might decide that they don't want their digital footprint to be impacted by cancer. or what have you, right? So I think that to insert a more humanistic approach in all that we do, whether it's medicine or research, is key to that. When we see ourselves in our patients, when we see our family members, when we see our grandmothers, grandfathers, our children, our nieces and nephews, we behave differently. And so I think to hold ourselves accountable to the humanistic aspects and not to, that's why I always talk about embodied knowledge and embodying our lived experiences and being mindful of that while maintaining scientific objectivity is really, really key. You know, and there's a fine balance, and it's our job to learn how to do that.
Mm-hmm.
Yeah, that's very powerful. Thank you. I think often probably underappreciated how exhausting that would be to be asked to be a representative for an entire population that your, experience is, generalizable to everyone else of your, gender, race, ethnicity. So I can certainly appreciate that, how we can improve this, our process and approach.
Mm-hmm.
Dr. Usher, if you wouldn't mind commenting, I appreciated your comment about involving social work from day one. To me, this is almost analogous to how we treat palliative care, that they're involved when there's a crisis, and that is such a unhelpful time to bring that service in, and wondering if you could comment on that, particularly in the setting of we personally, at our cancer institute, I know have struggled with, consistent social work support, and, it becomes a challenge, and I know they're stretched thin, and, wondering if you could expand more on that.
One of the things we're looking at here at UC Davis is the difference between being treated as an AYA cancer patient in peds and then being treated as an AYA cancer patient in the adult. Depending on, which clinic, we have both at our site. And one of the things that's unique about the pediatric oncology world, and I imagine other states are similar, is the social workers are actually required to be involved within the first month of treatment, provide assessments, to stay involved, and it's part of our funding source. And so you have to show that they're engaged throughout a child or teen's care, and our pediatric area will treat a pediatric protocol for patients up to age 29 even. And so what we see when we look at that, just incidentally, we're going to do a research a protocol for this, is that really improves the access to psychosocial care. It improves the access to learning about and getting help with oncofertility, financial assistance, college, the money that people can get to go to college. Why am I forgetting that name? Scholarships. Yes, there you go. Whereas in the adult population, so we have, and roughly about 450 peds patients total. So that includes teens and young adults, as well as all pediatrics. Whereas in the adult population here at my cancer center, there's about 12,000 patients. And so each social worker who's responsible for them has 1,000 to 2,000 patients each. There is no mandate that they be seen. And so the referrals come in when there's a crisis. And so how might we take a more pediatric model of psychosocial care and apply it to an AYA population? And this is the harder part of it, is how do we get the faculty who are used to having a lack of psychosocial care to go, okay, this is an AYA patient. Let's make sure from the get-go we have that. And I think it's a challenge for us, but it's something that we want to start to tackle because it really could make a significant difference for our patients.
Yeah, absolutely. Absolutely. I was also curious if you could comment on something that we've seen in the, kind of silver lining of the pandemic, that in some ways, for those that, with the major caveat that if you have internet access, right, it has increased access to medical care for those of our patients that we serve who live up in the UP, which, for those of you who aren't familiar with Michigan, is like 8 hours away. So
completely. Well, we all did that bumpy transition of trying to move support groups and supportive programs that we offered to a virtual environment, as well as the counseling, the assessments and the counseling that we provide to video visits. And what we found is that our uptake in our services when it went virtual had some significant patterns, and a lot more people from the outer areas who would have traveled or not traveled, would have skipped the event or the service, were able to engage a little bit more. So that's very exciting. I do want to say, and it's really, really, really important to me, that probably about 30% of our patients, for multitude of reasons, cannot engage on a virtual level. And that's, as a social worker, to me, that's a really important population that we need to make sure we're looking for. They're the ones that slip through the cracks, and they're disproportionately young adults. And so I want to make sure that we're looking at a multimodal way of reaching people, and paying attention to that. But to your point, the shift to virtual has really made a lot more accessibility. We saw a 57% increase in the number of patients who utilize psychosocial care. We had to hire 4 or 5 more social workers just to manage it.
Yeah.
Dr. Walling, can I say something as a follow-up to what Dr. Usher just said? In terms of the telehealth, I love one of the great things about the COVID-19 experience that Dr. Usher is mentioning about the transition to telehealth is that it's a fine example of how longstanding structures can quickly be dismantled and rebuilt, right? So before the COVID-19 emergency, we were at what there was a study done at University of California, San Francisco, where their adolescent health clinic had less than 5%, maybe it was 3% telehealth before the pandemic. Almost overnight, they shot up to something like 97%. I may be misquoting that, but it's in the high 90s. And so what that took was lifting 2 pieces of legislation, one that controlled what could be reimbursed. So before, telehealth could not be reimbursed. And the second was the type of technology that could be used, right, in the telehealth encounters. And so that just shows you, when we say, oh, racism, this country, so long, queerphobia, this country, so long, it's like, how do we change people's minds and how they feel? How do we make them good people? It's not always about that. There are sometimes like infrastructure things that we can just very quickly just make it happen overnight. We don't have to think like we need to get people to care about poor people in the rural areas and creating access. That's going to be you're not going to change people's minds about that. That's an internal ethical, moral thing that nobody changes their mind in a conversation or by looking at a pie chart or marching on Washington, right? It's we change those minds by sometimes just creating structural changes like that, lifting 2 pieces of legislation, and overnight, just like that, we got telebehavioral health. So the COVID-19 emergency, in terms of our healthcare system, there are awful things that we learned. We were exposed to the inequities, right? And we were exposed to some bad actors that we weren't aware of before, but there are amazing gains that we make that we should continue to build upon. So I just wanted to say that.
Yeah, that's an excellent point, because it shows you what is actually possible when you have the will and the urgency to get it done. Soon to be Dr. Oh, I'm sorry, please.
No, I was gonna follow up from Dr. Cheung's comment and thinking about as these healthcare systems transform and as we are in the midst of urging these transformations, one of the things that I think is really important in terms of reconciling previous gaps or previous harm to the populations we're talking about, as Dr. Erwin said, be real, kind of address them head on with our patients to some extent. I'm thinking about my dissertation research where I've been doing qualitative interviews with AYA, SGM cancer survivors. And some of my driving questions are around asking about experiences with medical institutions prior to their cancer diagnosis. And what I'm hearing is a lot of medical trauma and a lot of traumatic experiences that predate the cancer diagnosis. So I think that as part of that initial and ongoing assessment, soliciting information in, evidence-driven and appropriate ways about what previous gaps and harms are affecting the patient by the time that they reach their cancer diagnosis and care is critical, because a lot of the populations we're talking about do have historical trauma with medical institutions. And so accounting for that and not just saying the issues are everywhere, but in the hospital, but really kind of, as we're in this moment of reconciliation, kind of owning them and incorporating them into the process of transformation, I think is really vital.
Yeah, that's an excellent point. Soon to be Dr. Jackson Levin. We have two questions from the audience that I will pose to you guys. I don't believe they're directed towards anyone in particular, but the first one is talking about being transparent. Those of you who also belong to a population of interest, i.e. previous patient, mental health diagnosis, do you disclose this information to your patient population or not? If not, what is your rationale? And I see it looks like Dr. Cheung may be typing an answer, but if you wanted to.
I can just speak it, I suppose. So I absolutely disclose. It's part of my own advocacy in terms of being an embodied researcher, that I think that I want to disabuse researchers of the idea that we need someone outside of ourselves to interpret what's happening to us in our own bodies. I think that oftentimes, if we were to think of like just the naturalist, basic scientist, objective, idea of scientific objectivity, early on in my doctoral training, I was told, maybe you shouldn't focus on cancer because maybe you're too close to it, right? And I ignored all of that. I found mentors who would help me ignore all of that and actually optimize my positionality to the issue. I think it builds rapport with our participants. I think that it creates a safe space for them to do honest, true sharing. And also, I think as a qualitative researcher, even as a quantitative researcher as well, because I engage in mixed methodologies, I'm then giving you an honest insight into my instrument of data collection, which is me, and my instrument of data analysis, which is me, controlled by me, right? Even if I use artificial intelligence, I'm the one inputting the algorithm, that kind of thing, right? And so I'm sharing with you my orientation. And so with that, then you can populate your data collection with other perspectives. Then you can find someone like Nina, who has a different perspective from me, but can give you a different view of what's going on. So I think absolutely it's important. It has only benefited me. On the other hand, when it has not benefited me, it's because it's coming from within the research team. People will dismiss me as she's just a patient, right? So it's the inside baseball where I get dismissed. It's not.
You can't be objective with your research because
exactly. It's not the participants. So I also make sure that I'm always citing my research when I'm citing my research. And as Dr. Zebrack, early on in my training, him being a self-identified patient scientist himself, former AYA survivor, said, your science needs to stand on its own legs. And so I make sure that happens. And if anything, I'm more accountable to scientific objectivity because of that. I want to make sure that my methods are transparent and repeatable and all the things of good science.
Right.
I was just I think sometimes people might be asking as clinicians too. And I think that as clinicians, like, first of all, I want to say, I think people are at different levels of readiness about sharing parts of their identity. And I think that's always important for that to be a choice that you make yourself, that you should never feel pushed in either direction. But just as a clinician, I think there's this other lens of, is this helpful for the person who's in front of me as a patient or not? And that's really what guides our moment in the room as a clinician, as opposed to thinking about as an advocate or a clinician. So all those lenses are important.
Absolutely. Thank you. That's an important point, Dr. Erwin. And looks like you're going to field this next question too. I'll just read it aloud for the audience. Do you think mental health aspects should be handled by social workers or psychologists / psychiatrists? Our social workers are currently under case management and there are no psychologists.
I think there's fundamentally a need for teams. I think that the reality is we need to think about how to help all of us work at, like, this is not my favorite expression, but the highest level of our training. So fundamentally, people don't have enough expertise in medication management. So people who can provide medication management need to be able to do that with teams. And I think we need to think beyond social workers and psychologists. As much as I love my social work colleagues, and it's very much a team approach, we need to think about partnering with community health workers and navigators who are on the ground to really extend the reach of evidence-based therapies that are designed in ways that are like make sense for communities. And I think that's really the only way we're going to bridge the mental health gap.
And I wanted to just add on to that in terms of what Dr. Irwin said, and say that it's important to use the entire interdisciplinary team to get that initial, like entryway to the patient, and then pass it on to the highest level of training. Absolutely. I'm drawing this from my work on the financial hardship of cancer in military adolescents and young adults. And in that cultural context of the active duty military context, and with that younger population, we actually found that the hospital chaplain had the most insight into financial hardship. And so that person then passed it on to the rest of the care team, right?
I think thinking broadly about all of our shared experience, and really what I would say is who's there in your community? Like, who are the strengths and sources? That's going to look different at a community level, at a hospital system level. And that's what I think, that resiliency at a community level is really critical.
Awesome. We're right at 1 p.m. We want to thank all of you who are tuning in, listening, joining us, and thank again for Dr. Walling for facilitating, but more so for our four wonderful panelists contributing and sharing with us their expertise, focusing on health disparity in AYA Psycho-Oncology. The webinar now is over. Thank you for participating. All right, have a great rest of your day.